Hello, everyone. This is Dr. Mick recording a lecture on Chapter 37, which is the drugs and medications for viral infections, with the focus on the HIV/AIDS syndrome or disease. So this slides explains or illustrate the characteristics of viruses and the structure of the virus according to the anatomy and physiology, in which that the viral infections and injury, that it depends on the host cells. So the virions do not possess any of the metabolic organelles, which is usually found in bacteria. There is no metabolism or incapable of independent reproduction, and permissive host cell in which that the virion binds to receptors on the plasma membrane. Usually the viral infections is the self-limiting disease or infection in which that spreads cell to cell. Infected cell infects other cells, and also the viral pathogens bypass many defense mechanisms by developing the intracellular, like within the cells intracellularly. Thus, it will be hiding within the cells. So it's kind of the mechanism of this effect, bypassing this defense mechanism by developing that within the cell, and it will hide within the cell and away from normal inflammatory and immune responses. So it will kind of evade and hide from the immune responses and immune system. So that's why it's, kind of called self-limiting disease or self-limiting infection. And when we say virion, V-I-R-I-O-N, it includes the virus particle with its viral genome, DNA or RNA, and its protein coding. So all of this combined together, the viral particle and its viral genome, RNA or DNA, and its protein code, all of this together called virion. But we usually call this just the virus, but it's just beyond just the viral or the virus particle. It's so virion or virus. It denotes the same thing, but it's not exactly the same in terms of the structure and the pathophysiology. So DNA or RNA, the viral replication of the virus, either it has DNA or RNA, single or double-stranded. So protein receptor binding site. The virion becomes attached to the cell's plasma membrane by absorption. Second, the virion releases its enzymes to make the cell membrane weak and allow it to penetrate the cell. So it can penetrate the cell through that little opening. And the virus then uncoat itself, and the virus, number 4, that the virus will replicates, or replication of the virus will take place in the nucleus. So most RNA viruses directly produce mRNA, messenger RNA. The transmission of the messenger RNA, mRNA, results in the production of viral protein. Then the DNA provirus enters the nucleus and is transcribed into the mRNA, which is very similar to the HIV viral replication and infection or infectious process. How the HIV or viral, the infected HIV infected cells infect other cells, and we'll go over that and when we get to the HIV/AIDS disease. Then number 5, that's the matures and escapes. So this virus will get mature and it will escape from the cell, the infected cell, by budding from the plasma membrane. So number 1, the protein binding site, the virion becomes attached to the cell membrane, plasma membrane. by absorption. Then the second, or number two, the virus releases the enzymes to weaken the cell membrane and allow for it to penetrate the cell. And then the number three, the virion uncoat itself. Number four, that the virus now it enters the cell and it will now enter the plant, not just the cytoplasm, but also number four, to enter the nucleus and replicate itself in the nucleus. And that's when the translation of this messenger RNA that will result in the production of viral protein. And then we will talk about the translation and transcription inside the of this number, or step number four. We will explain that when we get to the HIV/AIDS disease, and we will explain more in depth about the translation and the transcription. Now, number five, we said that it will nurture and escape from the cell by the budding process, in which that the infection then can spread to other host cells. These new virions are now released through the budding process. So it's kind of detached from the infected cell and it will infect other cells. And the viral DNA that is integrated in host cell DNA is transmitted to daughter cells by mitosis. So this kind of explanation of the steps or phases of the viral replication. So once inside the cell, the virion have many harmful effects. Inhibition of the host cell DNA or RNA or protein synthesis, like herpes virus. Maybe other harmful effects would be like disruption of lysosomal membranes, like digestive lysosome enzymes, like herpes virus again. The fusion of infected with adjacent host cells, which is in which that there is production or producing a nucleated giant cells, like the respiratory system, the infections or viral infections affecting the lungs. Alteration of the antigenetic properties, and in which that identity of the infected cell causing the individual's immune system to attack the cell as if were foreign. So it's kind of similar to the autoimmune disease. And herpes B virus is one form of that. The transformation of host cells into cancer cells, that will be one form of this, or example of that, of this type would be the HPV virus, the human papilloma virus. And the promotion of secondary bacterial infections in tissues damaged by the viruses. Now, the therapy for viral infections, most viral infections are self-limiting infections, in which that it doesn't require any pharmacotherapy. No need for any treatment or medications, like rhinovirus that causes the common cold. So hepatitis, also some like type A, sometimes patients will be affected by this hep A, and it's patient develop or experience just malaise, low-grade fever, general weakness, and that will and patient will or immune system will be competent immune system will not be affected by or the patient's will not be affected by this viral infection, and the immune system will be competent and able to handle this self-limiting infection. So some viruses cause serious diseases and require aggressive therapy. An example of this, viral infections that are severe enough to lead to long-term and chronic condition, and also complications and probably death, as the HIV/AIDS virus. So if like HIV viral infection, it's fatal if left untreated. The herpes viruses also can cause significant pain and disability if left untreated. The challenges of the antiviral therapy is that the viruses mutate rapidly and drugs become ineffective. So these medications or drugs become ineffective because the virus or the viruses, they mutate rapidly. Mutation of the virus makes it very difficult for these traditional drugs, medications to continue the effectiveness or the same effectiveness. The difficult, it's also would say that difficult for drug to find virus without injuring normal cells. So we kind of, try to treat the patients like very, not similar to, but the same, concept of chemotherapy. You also, at some point, you will also damage the normal healthy tissue or cells. So right here, same thing is that, antiviral therapy, sometimes it will injure the normal cells. And each antiviral drug is specific to only one particular virus. So HIV/AIDS worldwide, these are the numbers: 2.7 million newly infected with HIV per annual, and over 33 million. And the number, of course, this is like not the most recent, but this is looking like approximate number of individuals live with HIV. And that's the global kind of worldwide, and these are the bottom, below here is the are the numbers in the US. And that's the HIVs. It's the RNA virus, and was discovered in 1983. Now it's called retrovirus, or it's an RNA virus, and it's called retrovirus. And retrovirus, from the word retro, because they replicate in a backward manner, going from the RNA to DNA. And I'll explain more on the pathophysiology of the disease process, how the virus will go from the RNA to DNA, in which all the other viruses would go from DNA to RNA. So it's kind of retrovirus because the replication of this virus goes in or follow the backward manner, going from the RNA to DNA. So the HIV cannot replicate until it's inside a living cell, like any other virus. And when it enters the cell, that's when the knobs, or the GP120 knobs on the viral envelope, they bind to the specific CD4 receptor site. And we said that the CD4, that's the T helper cells. T helper T lymphocyte is a type of T lymphocyte. A T lymphocyte or T helper cells called CD4. So this virus will attack this CD4, and there is a receptor for these CD4 receptors, and that's where the GP120 knob of that virus will bind to this specific receptor on the CD4 cell, and which the virus will bind to the receptor. It will infect the human cells that have CD4 receptor on the cell surface. So, like, the cells that are going to be affected by this disease or this virus will attack any human cell that have a CD4 receptor on the cell membrane, like lymphocytes. Even if there's any monocyte or macrophage that has a CD4 receptor, will be attacked. But mainly lymphocytes, monocytes, macrophages, astrocytes, and oligodendrocytes. So again, the virus will attack any cell with CD4 receptor site, like lymphocytes, monocytes, macrophages, astrocytes, oligodendrocytes. the HIV will cause immune dysfunction by destroying this CD4, like T cells, like T helper cells. One major or the majority of these cells will be T helper cells with the CD4 receptor. So the HIV destroys about 1 billion CD4 plus T cells every day. So on a daily basis, this is like the number of CD4 T cells that will be affected by this disease. So the T cells, if we just focus on the lymphocytes, T cells, T helper cells, because they have a CD4 receptor, as once they are attacked by this HIV virus, the human immunodeficiency virus attacking this CD4 T cells, about 1 billion CD4 T cells will be destroyed every 24 hours. So remember that when we talk about the lymphocytes and neutrophils and lymphocytes, well, lymphocytes, B cells and T cells, and we see that the CD4, the T helper cells can ratio with the CD8, which is the T suppressor cells, CD8, and the CD4 is T helper cells. The ratio is supposed to be 2 CD4 to 1 ratio, 2 to 1, CD4 2 to 1, CD8 ratio, in which, let's say, the normal average of healthy individual with the CD4 supposed to have a 600 up to 1200 CD4 count, and half of this will be CD8. So T helper cells compared to the T suppressor cells or the CD8. So 2 CD4 count to 1 CD8 ratio. If that person has, let's say, the CD4 count is 600, then we, anticipate that the CD8 would be like 400. If that's 1,000 CD4, then I would expect the CD8 to be like 500. So it's 2 to 1 ratio. In patients with HIV/AIDS, the ratio of CD4 to CD8 is reversed because of the virus attack the CD4 receptors. So once again, this is the pathophysiology of the replication and infected, or the process how the infected HIV cell, this one infects, this is a healthy cell, and how this infected cell infects the healthy cell. So once this infected cell with HIV once bound, then we have, these are the GP120. These are the protein-affected protein substances or molecules that are going to be injected. So binding, the GP120 binds to the CD4 receptor, and then it will inject the viral DNA into the cytoplasm of this healthy cell. So prior to become infected, this is the viral DNA. This is the infected viral DNA. Infected, injected here. So we have here an enzyme called reverse transcriptase enzyme, in which this reverse transcriptase will facilitate the production of the viral DNA using viral RNA as a template. So it will convert that. So it will use the viral RNA becomes a viral DNA. So again, the viral RNA becomes a viral DNA with the help of this reverse transcriptase enzyme. And now this viral DNA single-stranded. So this is the abnormal disease type of DNA, because it's supposed to be double-stranded. Now it's single-stranded. So once this viral DNA being injected, and then will convert to with this transcriptase into a viral DNA, single-stranded, we have another enzyme what the single-stranded DNA, then it will become double-stranded DNA and inject itself into the nucleus. With the help of the integrase enzyme, it becomes part of the DNA inside the nucleus. So the integrase will incorporate the double-stranded DNA, which is infected, again, into the normal DNA of the nucleus. So in other words, that this viral DNA become part of the human DNA. So this is the normal, healthy human DNA, and this is the viral DNA. So again, now at this point, the nucleus became infected with the HIV virus. And once this became infected, and then we have another enzyme called the protease enzyme, which will cleaves the long strand of viral RNA. So once this viral DNA inject itself with the integrase inside the cell, become part of the DNA, then at this point become infected, and then it will exit the nucleus. This became a viral RNA. Now it's ready for the budding process and to infect other cells, to kind of cleave or become detached from this cell. Now the whole cell became infected, and now at this point this becomes part. It will develop or generate and replicate a new infected cell. At this point, the cell infected and with HIV, and then it's ready with these kind of budding process, ready to integrate or to exit and to replicate itself and infect other cells. So in the cell membrane, the viral RNA is transcribed into a single strand of a viral DNA with the assistance of the reverse transcriptase, which is the enzyme made by the HIV. And the single strand of viral DNA copies itself to make double-stranded viral DNA. So again, just one more time, because we have two different processes or main steps of this whole replication of the HIV virus. One is called the transcription, and in which that the RNA makes copies, the single strand viral DNA makes copies of itself to make double-stranded DNA, and then we have translation. So we have transcription and translation, two main steps or stages within this disease process. The transcription, which is it takes place in the nucleus, inside the nucleus, make copies of the DNA, and then outside the nucleus, when it gets outside the nucleus, becomes the translation. So transcription inside the nucleus, and then translation outside the nucleus in the cytoplasm after became infected. No, the HIV destroys the CD4 in three ways. Either viral replication that leaves holes in the cell membrane, or infected cells fuse with other cells, in which it will combine to form a syncytium that destroys, like like another cell that will destroy all affected cells by the, by fusion. Infected cells would fuse with other cells. And the third mechanism in which how the HIV destroys the CD4, other than the viral replication that will leave the holes in the cell membrane, or the infected cells will fuse with other cells. The third one, in which that the antibodies against the HIV bind to the infected cells, and it will activate the complement system, which will destroy the infected cells. Now, the acute versus the chronic phase. The acute phase, which takes weeks to months, was something called the window period, in which that the antibody against the HIV, the infection with blood products compared to the infection due to the sexual transmission with blood products would take about 4 to 7 weeks, the window period. But people who have been infected due to the sexual transmission takes about like 6 to 14 months for the window period. So the initial infection is called viremia, in which patient exhibits like few clinical symptoms, and patient has a steady state of viral load that can be maintained for many years without exhibiting any complications or significant immunodeficiency symptoms. However, when the viral load goes up, or the patient's viral load increases, then a large amount of the virus will be present in the blood, and that and that's at this point, the individual become infectious to others. Chronic phase, it's takes many years for a patient to develop the late stage or chronic infection of HIV, which is AIDS, acquired immunodeficiency syndrome, AIDS, that will be the long term, which is like chronic, stage, and late stage of the HIV virus infection. These numbers are very important, in which that the immune system would be severely compromised. And as we said, that the ratio of CD4 to CD8 ratio would be reversed to, instead of 2 to 1, will become 1 to 2. This disease is obviously that patients with this disease will have immunodeficiency, and they will be at risk for opportunistic infections and diseases that will develop, that will contribute to the disability and death untreated. The immune problems start with CD4 T cell counts that will drop below 500. And we said the healthy CD4 count is at least minimum of 600 in a healthy person. But once infected, then that will drop to less than 500 or below. So the ability of the HIV to destroy the CD4 T cells will exceed the body's ability to replace these T cells or these CD4 T cells. So the resultant outcome is a decline in the number of the CD4 count. CD4 T count will drop and will decrease the immune system capability, and become immunocompromised. Now, the moderate immune problem would begin or start to occur when the CD4 count drops to less than, between like 200 up to 499, which is less than 500, as we previously said. But the most important thing is that once this CD4 count count drops less than 200, that's when the patient is going to develop severe immune problems, which most likely is going to be the opportunistic infections. So the major concern With this CD4 count less than 200, and its effect on the immune system is that patient will develop major concerns will be the immune suppression, and they will develop the opportunistic infections like Kaposi sarcoma, the infections and cancer, different type of cancer that occur in immunosuppressed patients, and that can lead to disability, disease, and death. Kaposi sarcoma, as we said, and cytomegalovirus, and PCP, pneumocystis carinii pneumonia. So the fragile, the HIV is a fragile virus transmitted only through contact with bodily fluids, blood, semen, vaginal secretions, and breast milk. The puncture wounds, needle stick are the most common means for the workplace transmission of bloodborne diseases. And a needle with the hollow bore that had been contaminated with the patient's blood would be the high risk situation. The needle with a hollow bore that has been contaminated with the patient's blood will be considered as the high risk situation. The other situations described would be much less likely to result in transmission of the virus. So the transmission through, say, sex with infected partner, exposure to infected blood or blood products, pregnancy, and breastfeeding. Now, the HIV may be transmitted via oral sex when mucous membranes or non-intact skin comes in contact with infected body fluids, like semen or vaginal infections or blood. The women who are HIV positive may get pregnant. Now, showering after the intercourse will not reduce the risk for HIV transmission. The antiretroviral treatment, ART, or medications to treat HIV/AIDS will lower the viral loads, but the client would still be able to transmit the HIV to others. Now, what is seroconversion? Before we get into the seroconversion, there is an acute versus chronic infection. The acute infection is like flu-like syndrome, acute retroviral syndrome, but the chronic HIV infection is generally asymptomatic early on. And when the CD4 count drops to 200 up to 500, the symptoms occur. So symptoms like candida infections, oral leukoplakia, oral hairy leukoplakia, fever, sweats, diarrhea, headaches. So when we mentioned about the oral hairy leukoplakia from leuko, or like white blood cells, and leukoplakia, Leukoplakia. Now, the oral hairy leukoplakia is a condition triggered by the EBV, which is Epstein-Barr virus, and it causes white patches on the tongue, especially on both sides of the tongue. These patches are very thick, whitish patches around either on the tongue, the top, or maybe like mostly will be on both sides of the tongue. These patches may look like hairy, and that's where where that term came from, the oral hairy leukoplakia. And this is like one of the significant manifestations of the positive HIV, like patients with who are presented, like, as we assess patients, and this could be one of the first signs to diagnose patients with HIV. But we have to rule out, like, other diseases, but this will be one of the significant manifestations of early signs of HIV. Because the HIV virus, the human immunodeficiency virus, often causes this condition or this manifestation. So symptomatology, the persistent generalized lymphadenopathy, which is like engorgement and swelling of the lymph nodes, that's also a common sign and early stage of chronic infection. Diarrhea, oral lesions, neural abnormalities, that may also be present, but more of a late stage of HIV infection. There is a one specific type of meningitis that's usually present in patients with HIV, which is cryptococcosis, which is a debilitating form of the meningitis, which is a cryptococcal meningitis that can cause seizures in patients with HIV/AIDS. So if we can, according to this table, to stage HIV in terms, like stage 1, 2, and 3, and then we have the last stage, which is at the bottom of the table. Now, so seroconversion, back to seroconversion. So screening tests detect, the screening test will detect the HIV-specific antibodies. It may take up to 2 months before antibodies can be detected, which the one we explained about the window period. It depends on the mode of transmission also. The lab test will measure the viral activity, like a viral load, for example, the CD4 count. This is important because we need the CD4 count and viral load for all the HIVs, like, clinic, the visits to these clinics. We usually do these two things, viral load and CD4 count, to assess the disease progression, and also the consider the no prescription or adding or adjusting or modifying and the plan of care, the medications, and to add or adjust these medications as part of the plan of care plan for this patient. Now, after the initial positive test, so we have EIA test. So this is about the diagnostic studies. We said first that's a screening test, detect the HIV specific antibodies, and that because the window period, it takes number of sometimes up to 2 months for these antibodies to be detected in the blood, depends on the mode of transmission. If that's what the blood product or through the sexual intercourse, and then after an initial positive EIA test, so we have an enzyme immunoassay test. The EIA test is repeated before more specific testing, such as the Western blot, is done. So diagnostic studies will go more in depth, and discuss it in Adult Health 2, Adult Health 3, about the screening, the EIA test, the Western blot, which is a confirmatory test for the HIV. So the Western blot test for HIV, again, I'll explain more about the diagnostic testing and diagnostic studies for HIV/AIDS in Adult Health 3. Now, The seroconversion, which has to do with when the patient became or becomes infective to others. And it depends again, that goes back to that window period and the mode, and also the mode of transmission. So it may take from as little as 1 week to several months or more after infected or after an infection with HIV for antibodies to the virus to develop. After antibodies to the HIV appear in the blood, now a person will test positive on antibody test. So in other words, that we have two different tests. We have the virus and we have the antibody test. Now, the treatment for the HIV/AIDS is called the high active or highly active antiretroviral therapy, HAART, or just you can you do the abbreviated term ART, antiretroviral treatment or therapy, ART. It reduces, so the goal of this therapy is to reduce the HIV RNA load in the blood, so we want to reduce the viral load in the blood to lower it to undetectable level or less than 50 copies per ml. Our goal also from this therapy is to increase the lifespan and to enhance the patient's quality of life, to decrease the risk of transmission from mother to the child, to also so the initial therapy or the initiation of the therapy, it may be initiated in acute phase when the patient is symptomatic, or in chronic phase, patient is asymptomatic. So the pharmacotherapy is very important, and we'll go over some indications included in the ART group. So we have 5 groups of medications or classes used to treat various HIV, AIDS, or patients with HIV, AIDS. And we have the nucleotide reverse transcriptase inhibitor. So the medications are actually, if you go back to the how the infection develops or how the infected cells infect other healthy cells, you'll find that, we're trying to attack these enzymes like reverse transcriptase enzyme, which converts this viral RNA into single-stranded RNA, DNA. And also the integrase enzyme here. We attempt also trying to counteract and inhibit this enzyme, the integrase, or we have another one, the protease enzyme, which has to do or has a major effect, function in this budding process or phase of the disease process. So we have 3 enzymes, 3 main enzymes: reverse transcriptase enzyme, we have the integrase enzyme, and we have the protease enzyme. So I would say most of these ART medications, they attempt to inhibiting these enzymes. So we have the reverse transcriptase inhibitors. We have also another group of medication called protease inhibitors, PI. Another third group of medications, they are reverse transcriptase. I'm sorry, in the integrase inhibitors. So again, most of these medications, the mechanism of action, it has to do with or to inhibit these enzymes, which can assist the infected cells to infect the healthy cell and the spread of the disease to other adjacent healthy cells. So it's most kind of inhibiting these enzymes and to stop the disease process. So the drug resistant develops quickly unless the patient takes the ART medications on a stringent schedule. Now, the other information is also important to consider, but the patients who are unable to manage and follow the complex drug treatment regimen should not be considered for the ART. So because this ART drugs has too many or lead to or causes too many side effects, most of patients will become non-compliant with the drug or with this plan of care or these ART medications. So compliance is one of the main factors for the management of this disease, or the effectiveness and management of these medications and these drugs. And the best approach to improve the adherence is to learn about the important activities in the patient's life and adjust the ART around those activities. Now, who would be the candidates for the ART, the antiretroviral medications? We can prescribe the ART for all different, all patients affected by the HIV or as HIV positive or, HIV AIDS patients, but we have candidates for each ART. Like, for example, CMV retinitis, cytomegalovirus retinitis, is an AIDS-defining illness. And it indicates that the patient is appropriate for the ART, even though the HIV infection period is relatively short. Usually it's 2 years since diagnosis of with the HIV. A second group would be like an HIV negative patients would not be offered the ART. So the patient with a CD4 count and the normal range would not typically be started on ART. So even though that's HIV, let's say positive, and the CD4 count is within the normal range, they will not be considered for the ART. A patient who drinks alcohol heavily would be unlikely to be able to manage the complex drug regimen. This HART requires that the patient should take more than one drug several times a day, 4 up to maybe like 6 times a day. And so this patient would not be appropriate, or this regimen would not be appropriate for ART despite the low CD4 count. That's the patient who drinks alcohol heavily would not be unlikely to be able to manage the complex drug regimen and would not be appropriate for ART despite the low CD4 count. So these are the 4 or 5 different groups of medications, and it has, as mentioned earlier or previously, about the medications or drugs here are basically the mechanism of action is consistent with the inhibition of these enzymes that would assist the virus to infect the healthy cell and transmit it to infect other cells. Zidovudine, Retrovir, which is one of the which is prototype drug for the nucleotide and reverse transcriptase inhibitors. For this drug or this group of medications, the nurse should monitor the patient's CBC to determine whether the patient has anemia or neutropenia. Because one of the side effects of this drug is anemia and neutropenia. The deficiency of vitamin B12 would be expected also here. So this statement indicates that the deficiency of the vitamin B12 requires that we have to supplement the patient with B12. So again, patient with high doses of zidovudine may experience or expect anemia, neutropenia, and folic acid deficiency anemia. The reverse transcriptase inhibitors like Sestiva, very common drug for HIV/AIDS. This drug, Sestiva, it can cause fetal abnormalities and should not be used in patients who may be pregnant. Sestiva. It is also important that the ERT medication be taken at the prescribed time every day. So, because again, we know all these ERTs, they are going to be prescribed more than once daily. So we recommend that, this concept kind of applies to all ERT medications to be taken as prescribed every day to avoid developing the drug-resistant HIV. And to measure the effectiveness of any of these ERT medications, the effectiveness of the ART medications is usually measured by the decrease in the viral load, the amount of plasma virus as being detected in the blood, the viral load, and in addition to that, it will supposed to boost and enhance the CD4 count, and this kind of again apply to all antiretroviral medications, the compliance and the effectiveness of ART based on viral load and CD4 count. Another group of medications with the protease inhibitors like Kaletra, in which this drug inhibits the HIV protease enzyme, which is the enzyme that is responsible or in the budding process of the disease or the viral infection or the HIV, how the infecting healthy cells, and the protease is going to do the budding or to have part of the budding of the infected cell and infect other healthy cells. Now, missing any doses of the ART, as we said, that can lead to the drug resistance. So non-compliance with the drug can lead to drug resistance. Kaletra, one of the side effects of Kaletra, which is hepatic dysfunction. So Kaletra can cause liver complications. So that's which requires that the liver function studies or tests to be, assessed or done before the initial dose of the Kaletra, and frequently after the initiation of the Kaletra, that we have to do. First, we have to assess patients' any symptoms of hepatic dysfunction, and at the same time to have a liver function test to be done periodically to indicate a liver problem. The prevention, or in other words, health promotion and prevention of HIV. So this slide explains the two different modes of transmission and the health promotion for each type. And the current CDC policy policy is to offer routine testing for HIV to all individuals aged 13 up to 64 years old. Although lifestyle symptoms and sexual orientation may suggest increased risk for HIV infection, the goal is to test all individuals in this age group or range. The participation in the needle exchange programs has been shown to control the rate of HIV infection, and you can read more about the needle exchange program, in which they found that the participation in this program has shown or has been shown to control the rate of HIV infection. The decreasing the risk related to the perinatal transmission. Only 25% of infants born to HIV positive mothers, they develop HIV infection, even with a mother, when the mother does not use the ART during pregnancy or antiretroviral medication during pregnancy, that only 25% of infants born to HIV positive mothers, they tend to develop HIV infection, even when the mother does not use the ART, the antiretroviral medication or treatment during pregnancy. Then the percentage will drop to about 2% when the ART is used. So this explains the importance or illustrates the importance of the ART medication or the compliance of ART meds during the pregnancy. The perinatal transmission can occur at any stage of HIV infection, although it is less likely to occur when the viral load is lower. So the ART can safely be used in pregnancy, although some ART drugs should be avoided. But as we weighing the risk and benefit ratio, you find that the risk is way lower than the benefit. Testing and counseling, and then acute intervention. The client with this immunodeficiency syndrome or disease should avoid certain things because the immune system is compromised, so the immunosuppressed. So the patient or client should avoid eating like raw fruits and vegetables, salads, because of the risk of infection. The hands also should be washed whenever, returning home in immune immunocompromised clients should not share any toothbrushes or toothpaste, and there are certain interventions to be practiced to prevent the infection in patients with who are immunocompromised. The acute exacerbation, infections, cancers, debility, psychosocial, economic issues affect patients' ability to cope and to adjust to the disease process. Now, the patient who is immunocompromised, HIV, patients at some point, with the advanced disease, they may develop, especially when the CD4 count is less than 200, they will develop the opportunistic infections. And one of these infections is called the PCP, or pneumocystis carinii pneumonia, in which this type of pneumonia is an opportunistic infection that will not cause disease in staff, or in any healthy individual, or any person would not be affected by PCP unless the immune system is compromised. So the PCP, again, it's an opportunistic infection, and it's one of the criteria to diagnose patients with AIDS. HIV positive patients, again, this is the early phase, and patients may continue to live within this HIV just positive, not progressing to the advanced stage of AIDS, because they are compliant with the medications and recommendations and teachings. But at some point, if they become non-compliant, they are not adhering to the regimen, and they may develop or progress to the advanced stage, which called AIDS. And that's when, on one of the criteria, like a wasting syndrome, patients develop PCP, pneumonia, or cryptococcal meningitis, or cytomegalovirus, or cytomegalovirus retinitis, mycobacterium complex. All of these are, and certain types of cancer like Kaposi's sarcoma. All of these are criteria to diagnose patients with advanced stage of the disease process. Okay, so as we read the scenario for the case study, give you a few minutes to read it. So the first question is, which of the following questions would potentially yield the most useful information in this patient's diagnosis and treatment? And we are looking or trying to identify the risk factors that may have led to the HIV/AIDS disease and or HIV infection. Now, the answer is C. The patient's presenting symptoms are consistent with the oropharyngeal candida or thrush, while the risk factors for the development of the thrush include recent antibiotic use of inhaled steroids. Remember from last or we'll discuss it. We'll discuss it in this semester about the short-acting beta agonist, or I'm sorry, the steroid inhalation. The candida is, or the thrush is one of the side effects. So while this, the risk factors for the development of the thrush include recent antibiotic use of inhaled corticosteroids, and head or neck radiation. The thrush or the candida, oral pharyngeal candidiasis or thrush, is also commonly encountered in the immunocompromised patients, such as those positive for the HIV. So due to the patient's apparently benign prior medical history and the new onset of multiple complaints, in addition to her oral candidal infections, an HIV infection should be considered. In order to assess the patient's risk for HIV exposure, a thorough history should be taken. Now, the risk factors for HIV infection include unprotected sexual intercourse, multiple sexual partners, IV drug use, occupational exposure to blood or bodily fluids, blood transfusion, prior to 1985, before we start to have like the rigorous process for the screening and of the blood products. And also you can add another risk factor, which is the use of non-sterile equipment and the tattooing or body piercing. All of these are risk factors for the transmission of HIV virus. Now, which of the following immunizations is safe to administer to this patient? Remember that this patient is immunocompromised, and we're looking for or trying to identify the correct one among the all 5 of them, or these vaccines or vaccinations, is the one that in which that patient's immune system is compromised can handle it. Should not be any active or live organisms. So A, which is inactivated influenza vaccine. So generally, the individuals positive for HIV should not receive live vaccines. So the administration of the inactivated influenza vaccine is recommended annually in all individuals positive for HIV. Live attenuated influenza vaccine was FDA approved in 2003 in an intranasal formulation, but is contraindicated in individuals with any immunosuppression, and a patient who is immunocompromised should not receive this live attenuated influenza vaccine. So which is the second, the FluMist, the intranasal formula. Still, it's the immune system is compromised and cannot handle this type of vaccine, the FluMist. The varicella MMR vaccines should not be administered either to patients with severe symptoms of HIV infection. The OPV, oral polio vaccine, or virus vaccine, is no longer recommended for use in the United States, despite its continued use in many other parts of the world. The IPV, instead, we have inactivated polio vaccine, which is IPV, inactivated polio vaccine, is recommended, and it's safe use for HIV positive individuals. So let's say that this will, if I change, let's say that the distractors, it can, like, if we are going to change this D, oral polio vaccine, because it's no longer used in the US, with IPV, that would be also the answer as well. So you can include A, inactivated influenza vaccine, and IPV, inactivated polio vaccine. Inactivated polio vaccine. Both are safe to be given or administered to the HIV positive individual. A patient has been treated for HIV infection for 7 years, has developed fat redistribution to the trunk with wasting of the arms, legs, and face. The nurse will anticipate teaching the patient about D, which is change in antiretroviral therapy. So frequent first intervention for metabolic disorders is a change in ART. Treatment with antifungal agents would not be appropriate because there's no indication of fungal infection. A change in diet or exercise have not proven helpful for this problem. The nurse is caring for an HIV positive client, which is what assessment finding assist the nurse in confirming progression of the client's diagnosis of AIDS. In other words, we're looking for the criteria for diagnosis. D, so the candida or the thrush, thick white patches on the client's tongue, especially both sides of the tongue. This candidiasis, which presents with thick white patches on the tongue and oral mucosa, it's usually associated with the development of AIDS after HIV infection. In other words, it's kind of like late advanced stage of the disease process, especially for for those who are non-compliant with the treatment. So the fact that the client has been positive for 8 years or has a low-grade fever is not significant. No, the nurse has been exposed to HIV through splashing of the urine from a client who is HIV positive with a low viral load. Now, the urine get into contact with the nurse's face. Which drug regimen does the nurse prepare to initiate? And this is according to the CDC protocols, and the CDC, Centers for Disease Control and Prevention, they have developed a guidelines for the post-exposure prophylaxis. So the nurse's exposure requires a basic PEP, post-exposure prophylaxis, with 2 drugs for 28 days. That's the protocol. Zidovudine and epivir for 28 days. Here we have a client visits an outpatient clinic and reports the night sweats and fatigue, states he has cough and has been nauseated and is having abdominal pain, frequent diarrhea, and the temperature is 100.6 Fahrenheit. Patient states has HIV, but his the monogamous partner for many years does not have HIV. Now, which is the following stage of the infection is the client experiencing at the moment? The client has AIDS, which is the 3rd and last stage of the infection, which is stage 3. The client is symptomatic, like cough, fever, diarrhea, which indicates that patient's immune system is significantly compromised, deficient, and he is no longer able to fight off these opportunistic infections. So there are only 3 stages in the categorizing the stages of AIDS. So patient is kind of late stage, stage 3. Second question, which of the following client statements reveals the need for reinforcement of teaching? The first one, if I have HIV, then I also have AIDS. That's incorrect. I can only transmit HIV in stage 1. In stage 2, that's incorrect as well. So these two statements are incorrect. So they need reinforcement by the nurse. So everyone who has AIDS has HIV infection, but not everyone with HIV infection has AIDS. Because remember that the AIDS is the advanced late stage. So HIV can be transmitted during any stage of the infection, but is more likely to spread right after being recently infected, the HIV infection. A diagnosis of AIDS is made when the client has the HIV infection and when the CD4 T cell count drops to less than 200. And that's when the patient develops one of the or more of the criteria for AIDS, such as the opportunistic infections and Kaposi sarcoma, PCP, pneumonia, pneumocystis carinii pneumonia, or Kaposi sarcoma again, wasting syndrome, and others. So that's when the patient is diagnosed with AIDS. Now, preventing the spread of HIV IV to his partner is important. Which of the following is considered a safe sex practice? Now, the three answers for this question would be the first one, only have sex with your partner. Third one, a fourth one, which is make sure the condom is correct size, and the last one, which is leave space at the end of the condom for the semen. So um, the first one, the fourth, and the last statement are correct. And the last question about the diagnostic testing and the confirmation of the disease process, and the answer would be the Western blot test, which is the Western blot test, which is supplemental HIV antibody test used to confirm diagnosis of HIV infection. The platelet count, liver biopsy, and differential, they are useful in evaluating the physiological status of the client, but do not confirm or suspect diagnoses of HIV. And next is the pharmacology of the herpes virus infections, which is a family of the DNA virus, causes repeated blister-like lesions in the skin, genitals, and other mucosal surfaces around the mouth also. So the antiviral drugs lower the frequency of acute episodes and would diminish the intensity of the acuteness of the disease process, and so it will relieve the acute symptoms, will prevent occurrences of the disease, but do not provide cure. The first and the prototype drug is acyclovir, Zovirax, a very effective antiviral drug for herpes viruses. So acyclovir is the drug of choice for most infections caused by the herpes simplex virus and varicella zoster virus. There is another drug called the ganciclovir, which is the drug of choice for prophylaxis and treatment of CMV infection, cytomegalovirus, and immunocompromised patients, including those with HIV/AIDS disease. Some of the side effects of acyclovir can cause renal damage and hydration of the patient during the infusion and for 2 hours afterward would minimize this risk, which is the dehydration. So dehydration is risk or adverse effect, and to prevention would be hydration, if IV infusion and hydration.